Hey guys, my name is Mike Loria, and this is my Checklist Manifesto. To start out, as far as disclaimer and disclosure goes, I have no financial conflicts of interest. This talk is about how the role that I believe that clinical checklists play, in particular checklists for rapid sequence intubation, and based on my experience both in the military as an aircrew member, as a civilian aircrew member, and doing pre-hospital air medical transport and critical care transport, as well as now in the ED and ICU. So, sort of to give a structure to this quick talk, I just wanted to go over briefly the origins of the checklist, then talk about where I think we've gone wrong in terms of their design and implementation, talk about structure, function, and application, how I think they should be implemented, and then why I think it's important, and some of the benefits that I think we gloss over when it comes to using checklists. So let's start at the beginning, the origins of the checklist. So going back to 1935, we were actually looking at gearing up for potential conflicts overseas already, and the Boeing Corporation had developed a brand new, beautiful aircraft, a bomber that they'd called the Model 299. And on October 30th, 1935, they were actually going to demonstrate it for the United States Army. So they had two amazing test pilots. The chief test pilot was Major Hill, and the co-pilot a Lieutenant Putt. They also had a very seasoned crew on board, and they basically increased the throttle, started heading off down the runway. They got into the air and began to climb and climb and climb and climb. And before you know it, the aircraft was pretty much vertical in the air. And the Boeing engineers watched in dismay as the aircraft stalled and tumbled to the ground, landing in a giant explosion and turning into a hulk of twisted metal and flames, which very sadly ended in the death of the chief test pilot, Major Hill. Very, very unfortunate and sad event. The Army basically said, this aircraft is too complicated. It's too much for any pilot to fly, and there was significant doubt as to whether or not it was actually going to come into the arsenal. However, the Army, some very motivated Army pilots that believed that this was not the case, it was not too complicated, in conjunction with engineers at Boeing, got together and they developed a better system. They developed checklists both for normal procedures, takeoff, landing, as well as emergency procedures in the aircraft that helped the very seasoned, very capable Army pilots function or actually operate a relatively complicated but ultimately very successful and very capable aircraft. And it's a good thing they did, because it's one of the aircraft, it became the B-17 Flying Fortress, one of the aircraft that really helped us win World War II, which is an important piece of military history. But fast forward a few decades, and over time, many of these safe systems operations techniques, such as using checklists, started to infiltrate other areas of high-risk occupations. And one of those areas was actually thanks to our anesthesia colleagues. So our anesthesia colleagues throughout the 80s and the 90s began to incorporate some of these human factors concepts like crew resource management, looking at things like non-technical skills, and actually developing concepts such as anesthesia non-technical skills that focused on these human factors like stress, cognitive load, communication during induction of anesthesia. And they were really the ones that brought many of these concepts into acute care medicine. Special thanks to very engaged researchers like David Gaba and his colleagues, who did a ton of work on this stuff in simulation. And over time, these came into the anesthesia vernacular, became a regular part of training, and became more popular, and there was more research. Ultimately, I should say initially, The checklist was a much smaller part of this, but throughout the late 90s and 2000s, especially after the publication of To Err is Human, um, they came more to the forefront. And with the culmination in the popular literature in 2009 in Atul Gawande's publication of this fantastic book called The Checklist Manifesto, where he explores the use of normal checklists in surgical operations and other clinical operations to improve safety. Fantastic book. Unfortunately, by some, its findings and its conclusions were extrapolated perhaps inappropriately. And that's where I want to talk about where I think we've gone wrong. So since the mid to late 2000s, we've seen the proliferation of many different forms of checklists for rapid sequence intubation and rapid sequence induction. They have taken on many forms, and I would argue that their construction, development, and design is not in best practice with how experts in the field of aviation, other high risk communities, and other high risk occupations, and people who study human factors and checklist design would design an aircraft. Or would design a checklist rather. And I think that explains the big question of, well, why do people not use the checklist more? Why, when they use the checklist, do they not show benefit? And I think when we look at it, it becomes a little more obvious. There was this fantastic, very well designed multicenter randomized trial of checklist use for endotracheal intubation in critically ill adults that was published in Chest. Very well designed study, but it didn't show any benefit. Likewise, there was a recent meta-analysis of various studies looking at checklist use for intubation, RSI and intubation, which was discussed in his fantastic post on First 10 EM by the illustrious Justin Morgenstern, a fantastic discussion of some of the methodological issues with this meta-analysis. But I would point to more foundational aspects of how the study was executed and designed. And I got to throw the red card up here and call bullshit, because at the very underpinnings of the studies, we're looking at the effectiveness of the checklists. But if the checklists were poorly designed and designed incorrectly to begin with, I would argue that, of course, I would expect to not see much benefit from a poorly designed checklist. And what we have to understand is just putting together a list of shit does not make a checklist. They are designed very carefully and with purpose and reviewed and tested and changed. And when we just go into it, putting in a bunch of things that we think we need on this piece of paper before intubation, that does not make a checklist. And I think they're failing because we're using them, if we're using them, we're using them incorrectly. And it's not because we're dealing with people in the emergency department, the ICU, or the OR who are not intelligent or not capable or don't care about patient safety. It is because when we have smart people that are very capable and experienced, they will ultimately figure out that these tools are ineffective and then just stop using them. They naturally find the most safe and efficient way to achieve things, and if we do a poor job of designing tools to help them, then those tools just don't get used or get used ineffectively. So it's about system design and checklist design. Furthermore, I would hasten to add that when we think about the benefit of these interventions and we look at a lot of these studies that show that they are not helpful, we have to remember that utility is basically the ratio of the amount of benefit we get out of something divided by the potential harm. So it's in the numerator, the potential benefit or reward, over the denominator, the potential harm or risk of a procedure or using an intervention. When we poorly design things, we essentially negate the benefit. We don't see these peripheral benefits that I will talk about later that I think are actually much more than peripheral, and we induce essentially potential harm or risk by making them long and unwieldy. When the checklist itself takes 3 to 5 minutes to run through, you're delaying time to a critical intervention, and that in and of itself induces essentially iatrogenic harm potentially. So I think these are reasons why how we've sort of gone wrong, and reasons why we're not seeing benefit in the literature. Now I want to touch on several very, very important concepts that I think are not recognized when people design checklists. First, the concept of a normal versus an emergency checklist. Okay, so this is very important and something we talk about all the time in checklist design. A normal checklist is a longer, more comprehensive checklist that is designed for situations that are not time sensitive. So like going through the code cart at the beginning of the shift and making sure all the equipment is there. Not necessarily time sensitive. You're very thorough and careful going through the checklist to make sure everything's there. Just like when I show up to a flight shift, we're very meticulous in checking out the aircraft and making sure all the equipment is there. We would never do this right before a mission because it takes many minutes to ensure that everything is there and ready to go. I would hasten to add also that this is primarily the type of checklist that Atul Gawande was talking about in his book, The Checklist Manifesto. These are normal checklists designed to improve surgical safety in important and perhaps urgent, but not necessarily emergent surgical procedures. So we have to understand that, and I think that's one of the reasons why when people talk about the looking or read or interpret the checklist manifesto and then use that to design emergency checklists, we're doing it perhaps incorrectly. And now these normal checklists are different from emergency checklists. Emergency checklists are designed for cases like, for example, when you lose an engine in an aircraft or it blows up, sending shrapnel into the fuselage and critically injuring a number of patients. This is a situation that has to be remedied immediately. The checklists that we use in these types of situations are generally shorter, they're more concise, and they're just going over critical elements that you need in order to safely land, or in the case of RSI, safely intubate the patients. This is actually how we should be designing our RSI checklists, for example. Standard operating procedures versus what's on a checklist. In all operational environments, we do not have, we actually use, I should say, standard operating procedures to shall I say, shorten or make us more efficient when we're executing time-sensitive operations. In other words, when we are going out to perform or when we were flying out in the military in the pararescue community to go perform our rescue of a team that had been critically injured or wounded in, let's say, an IED blast or something along those lines, we don't get to the aircraft and then pause and make sure that we have our body armor and everything is in the body armor and everything is in our medical kits and we're good to go. We check all of that beforehand, and or there are standard operating procedures in place so that we say, okay, standard loadout will be conducted today, or you make sure you have your standard loadout, or we operate in accordance with, or we're going to do this mission in accordance with standard operating procedure. That actually shortens things, it abbreviates things, and it obviates the need for putting those things on a checklist. The briefing versus the checklist. Briefings are designed to be more like discussions, to share an idea or a concept, to review important things like emergency egress procedures or what might happen if we encounter XYZ situation. This is very different from using the checklist. The checklist is just designed to make sure that you have accomplished or mitigated anything that you talked about in the briefing, to make sure that you have all the critical pieces of equipment, that all the T's are crossed and the I's are dotted, and it is performed right before you take off. So when I see people design checklists with things like, toward the end of the checklist, right as you're about to push the induction agent and get ready to go, things like consider causes of hypotension, or evaluate for signs of right heart failure, or anything along those lines, those items do not belong on the checklist. They are moved to the beginning, before the checklist is even executed, to a quick airway briefing. Right before you're getting ready to put the tube in the trachea is not the time to have the conversation about problems with hypoxia or hypotension. Those need to be addressed, mitigated, and prepared for earlier on. a quick review of a couple of other things that of what a checklist is not or should not be. It's not a user's manual. It's not designed to take you through step by step of preparing equipment or step by step of performing a procedure. You have to know what the individual pieces of equipment are, how you set things up. You also have to know the steps of the procedure. The checklist is not designed to do that. It's just designed to make sure you have the critical elements necessary to perform the procedure to avoid adverse outcomes. Likewise, I am all about cognitive offloading tools. Going to standardized drug cards, especially for pediatric patients, using things like the Broslow tape or a length, any other brand of length-based tape to quickly identify based on a child's height what the appropriate size of equipment are, all that other stuff. However, it does not belong on the checklist. An emergency checklist needs to be clean. It needs to be easy to read. It needs to be void of any sort of distraction up to and including size charts or equipment charts or drug charts or anything along those lines. Kind of like I talked about in the briefing, a checklist is not a time for discussion. The discussion, the teaching, all of that stuff comes before you actually get ready to execute the checklist and perform the procedure. It comes up front as part of the briefing. Likewise, a checklist is never, ever a clinical crutch. It is never a good substitute. It is never a substitute at all for good clinical decision making or deliberate practice, training, and development of clinical skills. You still have to put in the hard work and the time to read about pulmonary physiology and understand the hemodynamics of the trauma patient and understand the equipment when it's designed to work under what situations and which piece of equipment is best. All of that stuff you still have to do. The checklist is not designed to help you with that. So when I see things on a checklist like, does this patient have blood in their mouth? Then consider using this. Or if the patient has this, then go ahead and consider that. No, that is the stuff that you have to understand and consider beforehand, talk about in the briefing, that is not part of a checklist. So this is perhaps the most important slide in the whole presentation. If you can remember anything from this talk, walk away with this. What are good elements of a checklist? An emergency checklist should be short and to the point. It should contain critical items only. It should contain specific responses or actions. It should be easy to read, so the print should be relatively big, block text with no distractions, easy to read, and it should be sequential and logical flow. It shouldn't necessarily be organized into pots or silos based upon type of checklist item, like talk about all of the preparation stuff, talk about all the stuff for the patient, the team, the this, the that. No, it should be organized in terms of logical and sequential operational flow as opposed to just sort of sorting items with other like items on a checklist. So I think we've kind of been heading the wrong way. I think a lot of this is due to the fact that we've been reading the Checklist Manifesto, we've been reading other publications on checklists, and we've ignored largely the evidence behind checklists, and we haven't delved as much as we should into the human factors literature. We've incorrectly generalized the literature and science behind checklist design. We've made normal checklists for emergency situations. We've misconstrued briefings and checklists, and even when we have checklists, they've been poorly designed, bulky, cluttered, and take way, way too long. But I think we can fix these things. So what is the true structure, function, and application of a checklist? This is the mantra. You brief, prepare, check, and perform. Once again, that's brief, prepare, check, and perform. So let's start out with the briefing. The briefing is the time to basically share your idea, your concepts, what you want to have done, and things you want to look out for with the entire team. So this is an example, and I'll take this moment to throw in a caveat here. These, both the checklist and the briefing, need to be sort of tailored to your institution. So based upon our faculty, based upon our residents, based upon the other staff that we have with us, our respiratory therapists, and the teams available in our hospital, for example, you can see in that first line item the DART, or DART, is our difficult airway response team, which has additional anesthesia members and ENT members to come down and help with particularly difficult airways. So this is designed for our institution, and it's basically to prompt people to, okay, remind, we got to get everybody here, we got to get all the equipment together, but most importantly, we're verbalizing our plan, verbalizing the drugs and medications we're going to use, and discussing potential problems. Is this going to be an anatomically or physiologically difficult airway? How are we going to address hypoxia and hypotension? And then getting very important time-sensitive things going now, like the need to pre-oxygenate and denitrogenate the patient going right away. So the briefing is very, very important, and the fundamental cognitive psychology underpinning of the briefing is the ability to share your mental model and concept of how you want this to go, what you anticipate, and the key things that need to be involved. Mental models, or mental representations, as some cognitive psychologists refer to them, are your brain's way of constructing very rich, complicated models of how a particular procedure or piece of equipment is supposed to work or function, and condense it into and or around a particular framework or word, such as, for example, laryngoscopy. When I say laryngoscopy, that means much more than the word, right? So when I say laryngoscopy, you may think about the laryngoscope that you have in your emergency department, your OR, or your ICU. You may think about hyperangulated versus, or the different geometries of blades, hyperangulated versus Mac or Miller blades. You may think about the other equipment like the endotracheal tube, sizes, types, bougies, all the associated personnel that are around you that are helping you, whether it's an anesthesia assistant or your respiratory therapist, the nurses, who pushes the drugs, how everything works is condensed into this mental representation or this mental model. What's really cool is that when we share that mental model, when a team, everybody understands their role and their place and their job, what we see is very distinct benefits when we study these things, both in the real world and simulation, in terms of team performance and time to critical intervention. So what do these shared mental models actually do? Well, number one, they actually decrease the cognitive load. When you don't have to think about all the other pieces of the puzzle, you can actually focus on what's most germane to you and what your job is. More importantly, people actually report subjectively less stress and anxiety when we get rid of ambiguity, when we explain what the plan is, when we know what everybody's job is, when we know what medications we're going to use and what difficulties we anticipate. People actually express that they feel more comfortable. They feel like they have an idea of the plan, and that leads to less stress. It also leads to increased task focus. When people aren't concerned about what other people are doing because they know different things have been addressed, when they know someone is actually hanging the presser, when they know someone is already getting the blood and plasma onto the level 1 infuser, when they know that someone is responsible for a particular piece of equipment, they are able to focus better on their particular assigned task. What's more is that there's better situation awareness. When you actually say explicitly, hey, I'm worried about this patient getting hypotensive, so let's start the blood, let's do this, let's do that, or I'm worried because this patient is septic, and when we give them the induction medication, they may become hypotensive. Whatever you're worried about, when you express your concerns and the anticipated difficulty, it allows people to be on the lookout for that. It raises their antennae, it gets them prepared, and it preps their brain to look for key findings associated with what you're looking for. In fact, sometimes we'll see when you talk about those things, people will anticipate those things. They'll look for those things. They might cycle the blood pressure cuff in anticipation of those things, for example. And anticipation is actually anticipating, predicting, and coordinating the activities amongst the team is probably one of the key things that we see correlates very well with expert team performance. If I know, for example, that you've said this is probably going to be an anatomically difficult airway, if we can't oxygenate, we can't ventilate this patient, we will perform front of the neck access surgical cricothyrotomy. If I am watching my partner struggle at the airway and I see them and they can't get any airway, they can't see any airway structures. There is significant damage or contaminants that are preventing the patient, that are preventing them from seeing the glottic structures and visualizing the vocal cords, for example, then I know things aren't going well. And as I'm watching the SATs begin to drop, I may go ahead and take a step ahead and clean off the neck, put some betadine on the neck, already find the structures, the laryngeal cartilages and the cricothyroid membrane, and palpate that stuff on the neck. So at the moment my partner says, I am in a failed airway, I cannot oxygenate and cannot ventilate this patient, please perform a surgical cricothyrotomy, I'm already ready to go. I've anticipated that situation, and I'm already ready to perform that procedure quickly and efficiently. Then, so you brief, talk about all these important concepts and what's your plan, and share your mental model. Then you just prepare. Go ahead and get all the stuff ready, whatever you use at your institution, get it ready to rock and roll, put it all together. Now, the check. This is where the checklist comes. This is right before you perform the procedure. This is essentially like the quick timeout to make sure you have everything, the quick safety check. This is where the checklist comes in. This, again, is an example that we have, as a group, agreed on at our institution. It is relatively short. There's only about 10 or 11 items on here. It reviews what we believe are the things that we tend to forget or have issues with most commonly. It leaves off things that we've not had issues with or are part of our standard operating procedures. It flows relatively quickly and efficiently, and when done correctly, it can be completed in about 20 seconds or so. And I would add that we've added a couple very important things at the end. For example, asking everybody if they have any safety concerns, and finally asking everybody to be quiet for induction. So this is the quick checklist to make sure that all of the things you briefed have been addressed and everything is going as planned and there are no major safety concerns or pieces of equipment missing. Then go for it. Perform. Go ahead and push the induction agents and execute the plan that you have already pre-briefed. Okay. Now, I will also add that last part, the perform part, is generally the most complicated, but I'm just focusing on the briefing and the checklist for purposes of this presentation. Now, but why? Why? What is the benefit of the checklist, and why should we be using it more often? Well, first and foremost, most commonly people think that this is it, the decreased cognitive load. And yes, there is a reduction in cognitive load when you use the checklist. People do believe that, and when we see that and when we study it, we're offloading things that people are thinking about. They feel more comfortable. They know that all their backups are ready and prepared, and you have the right medications, and that stuff is good. And we also know that going through that checklist and having some semblance of control in a very uncontrolled environment seems to decrease stress. But I would actually argue that these two concepts, these two things, the decreased cognitive load and the decreased stress, are only part of a much bigger picture with some additional benefits to using checklists that I think we overlook. For example, developing automaticity and habit. This is particularly important for our learners, for our paramedics, flight nurses, trainees, residents and registrars, anybody else learning to develop very strong habits. So when we go through the checklist over and over again, when we make uniform our practice, they get a baseline of how things should look, how things should be set up, how things should be going. That automaticity and that habit formation is very important moving forward. In fact, when we evaluate very expert pilots or expert personnel in a number of different domains, what we see emerges, because they've been practicing with a particular checklist for a long duration in their career, it develops what we call the flow and check habit formation and checklist usage. So they actually have become so accustomed to performing the checklist that before they even do the checklist, they're already getting everything done they know is on the checklist. They're already getting out their equipment. They're already putting everything in order. They're already making sure that the drug doses are good to go. And therefore, when it actually comes time to use the checklist, that checklist is very quick, and it is just a final safety check to make sure that all that stuff is there and functioning. Now, when we use this checklist and when we are asking other people to participate in the checklist usage, i.e. whether we're asking a nursing colleague to actually read the checklist to us, or whether we're simply just checking the drug dosage with a nursing colleague, Or at the end of the checklist, when we're checking with everybody, do you have any safety concerns? This is your time to speak up. We get better team commitment, ownership, and investment in the procedure. People feel like they actually have a say. People feel like they're actually participating, and that is important. Improved coordination. Much like the sharing of the mental model, when we actually go through the checklist and we make sure that everything is in order, in particular that we've addressed complications or we have the equipment that we need to deal with complications, we see improved team coordination and anticipation of action. And finally, we see decreased practice variability. We know that in general, when it comes to clinical practice, in particular emergency situations, lots of practice variability within an organization seems to correlate pretty well with more errors and adverse outcomes. When it comes to emergency procedures like airway management, which I perceive to be a very relatively high-risk procedure overall in the case of critically ill or injured patients, decreasing practice variability, I believe, can actually be very, very helpful. It's also, and I think this again goes overlooked in academic settings with our learners, if every time you work with an attending or a consultant who is telling you to do things differently, it is very difficult to get in good repetitions of deliberate practice, to build your skill set and get very good at doing something. So by decreasing variability, I think that's also good for education. When people ask me why I think checklists are good, I can go over all of these concepts and share the literature on human factors and whatnot and talk till I'm blue in the face. But I think it was summed up very nicely in a discussion I had with a retrieval colleague from Europe. So this is an attending or consultant anesthesiologist with many years of experience, more than 15 years of experience. And we were talking about using human factors in the operational environment because, this is a note for my friends in North America, in Europe and many other places around the world, if you're unfamiliar, when you call for a retrieval helicopter or a HEMS program to come and help you in the field, they generally believe that it is worthwhile to send a physician and a paramedic or nurse because if a patient is sick enough in the field that they need a helicopter, they need advanced medical care and the care of a doctor. So he is a consultant anesthesiologist that flies on a helicopter and regularly works in the pre-hospital environment. And I asked him, you probably don't need a checklist. You've probably done this, thousands of times. And the thing he said to me next was very interesting. He said, yes, I've done this thousands of times. However, when I was young and inexperienced and had only done about 500 to 1,000 intubations, which I kind of chuckled internally because for us, 500 to 1,000 is quite a bit. He said that I thought I knew everything. I thought I was prepared for everything. But over the course of the last 5,000 or 6,000 intubations, I've realized that no matter how smart I am, no matter how prepared I think I am, I often, in the heat of battle, forget things. My mind is also distracted by things that are going on around me, people that are asking me questions, changes in the patient condition. And he said, no matter how good I get, he said, I never think that I'm good enough to blow off that 20 or 30 seconds that it takes to make sure that everybody is on board with the plan. I have all my equipment and I'm prepared to proceed safely. And I thought, wow, this is coming from an experienced anesthesiologist, both in the hospital and out of the hospital, who's done somewhere between 6,000 and 7,000 intubations, and many, although not all of those, are in critically ill or injured patients. And that kind of summed up the argument for me. So think about your checklist design. Get into the human factors literature. Carefully review and refine your checklist and make it short, to the point, critical items only, clean and easy to read. Go through it and really work on it. It's worth the time and invested, and use it. So for my colleagues, both in the emergency department, the ICU, in the OR, and in the field, I don't necessarily think or am saying that we do a terrible job of managing airways or we're killing people left and right, but I think there's always room for improvement. And in these cases where the utility is such that there are significant benefits for a little bit of time investment, I think it is an investment that's worthwhile. I think these are the little kinds of things that take us from being good teams to great teams, trying to help out our critically injured and critically ill patients. If you're looking for more information on this topic, go ahead to mcrit.org or search mcrit ComCheck, on checklists for a full discussion and a review of the evidence of checklists in practice and how I think we can improve. Likewise, you can take a picture of this QR code or go to tinyurl.com, my checklist manifesto, and it will bring up the full list of references that I used to make this talk. Thank you guys so much for your time, and please be safe out there.